Great. My name is Rusty Hofmann. I'm the Professor in Chief of Interventional Radiology at Stanford. It's my pleasure to be invited here by Stan, of whom I work side by side with at Stanford. Is there any way the AV people could give me a time check or set the timer to, I just want to, number one rule in public speaking is don't oversend your welcome. So my actual real clinical work is in DVT treatment. First started in acute DVT with thrombolysis and stenting and the work with TPA and that dosing. And it's evolved over the years to what we call at Stanford the full metal jacket. It's patients that have chronic occlusion of their IVC and iliac veins, where I'll do a procedure that'll take anywhere from 5 to 11 hours to recanalize the IVC and iliacs and stent them from their right atrium to their femoral heads to help with swelling and venous stasis changes. Over the years, my work in collaboration with Stan has evolved into what can we do for patients that are diagnosed as lymphedema but may have underlying venous pathology. In full disclosure, this is a work in progress. I'm going to present some of the data that I've collected over the years, albeit not the best way to collect the data. And then I'll talk about some of the new things we're going to be moving forward. Here are my disclosures. Nothing that's really that pertinent other than stents that I use are manufactured by different companies. And as a true interventional radiologist, basically everything I do every single day is off-label, including this talk. So I'm first going to talk about how I work up patients in conjunction with Stan, review what we do, what we've learned at Stanford and what we don't know, talk about this registry, the VITAL registry that I have at Stanford that I'd welcome anyone's participation in, and then go over some case examples. So typically they come to me from Dr. Roxon or Stephanie D'Antoni. I don't know if I should know she's at the meeting. She works in Stockton and sends me patients. But I started doing CT venography on my acute DVT patients 15 years ago because I realized how underdiagnosed the thrombus burden was on my acute DVT patients with just ultrasound, because ultrasound sucks above the inguinal ligament. It's terrible. I never believe it, both at Hopkins and at Stanford. I was at Hopkins for 10 years, and I've been at Stanford for 10 years. Both times I've been completely led down the wrong path of either there is clot or not clot by the ultrasound, and they're wrong. So I believe cross-sectional imaging, I like CT venography the best because it's the highest resolution. In younger patients, I may consider MR venography, and you need to have someone that's dedicated to doing the right protocols for MR venography. CT venography is easier to do, and I can hand out or actually email anyone that's interested the protocols that we use at Stanford. So I go from the diaphragm to the toes, and it gives me tremendous amount of information in these patients. Number one, I find out if there's any veins that are occluded, which often can be an IVC occlusion that's gone undiagnosed for many years. I can pick up May-Thurner syndrome. That's the compression of the left common iliac vein by the right common iliac artery. How many people in the room are familiar with May-Thurner syndrome? I figured at the ACP I'd have a pretty high hit rate for that. So pick up that and quantify that. Also, something that I've stumbled across in the past year and a half is ovarian vein incompetence and how that leads to lower extremity edema. I also can see what the GSV anatomy is, how big it is, what the actually branching pattern is, and also look at actually the degree of discrepancy between the affected limb and the unaffected limb in terms of the adipogenesis that Stan talked about, the skin thickening and edema. I'm actually working with a data scientist back and an image informatics guy to develop an algorithm to automatically quantify that on all patients and use that to follow our results longitudinally in our patients. I then also get a duplex ultrasound in the superficial and deep system to see whether there's underlying reflux. So in my clinic, this is my protocol. I measure the circumference. at these 3 locations and bilaterally. Actually, my nurse practitioner does this for me, and use it for follow-up. And for better or for worse, I use the Villalta score and VCSS as a way to quantify all of my patients. I'm trying to now be a little bit more granular on the lymphedema patients that Stan sends to us. And this is something that I'm working on, developing an electronic version that will be emailed to my patients and Stan's patients prior to coming to see me in clinic. It's the QOL, and here's the reference. And this is what the form shows. It's one for arm and one for leg. So if you decide to do this in your clinic, I think it's a good idea to implement. Stan just sent this to me a few months ago. So what I'm going to talk to you, what we have the most experience at Stanford in is treating patients with May-Thurner syndrome that do not have acute DVT. So these are the people that either have a history of chronic DVT or don't have a history of DVT, they just have leg swelling, and we're trying to figure out why their leg is swollen. So we looked at all left-sided iliac vein stents placed in MTS between 07 and 14, and we came up with 45 patients. We actually, if you look at all patients that have been treated at Stanford for the past 20 years, we have about 300 patients that have been treated for May-Thurner syndrome with stenting, but this is obviously a small subset. We excluded 11 patients because of poor follow-up, so we had 34 patients that the majority had chronic left lower extremity, but some patients also had pelvic pain. We looked at the CT venogram or the MR venogram and really need to see a 30% stenosis, it's actually greater than 70% stenosis or 30% patency, that's a typo, and presence of upstream collaterals. And kind of a take-home message for you guys is if you look at the axial image, and this is the reference, this is 3 papers I've written, when I see the compression of the common iliac vein on the left be 4 millimeters or more, so if it's a 4 millimeter diameter, 3, 2, or 1, that's when I start worrying about this could actually be something that's attributing to the symptoms of the patient. And that 4 millimeter work actually comes out of this DVT work that I've done. So I actually have proven retrospectively that a 4 millimeter compression, the 4 millimeter diameter in a patient confers the same risk of DVT as active malignancy. Granted, it was a retrospective paper, but so it's a real risk for DVT, and I believe it has some applications in the lymphedema patient. So we went through the EMR, and we were not that scientific in the early days about really defining clinical outcomes. I would always ask the patients, are you better, worse, or the same? And so it was kind of reflected in, and we're, as a doctor and as a patient, that's really all they care about, whether it dropped by a little bit or got bigger by a little bit, inconsequential. It's really what impact it had on the patient. So the majority are female, which is not surprising considering May-Thurner syndrome is predominantly seen in women. 43 was the average age, and we had follow-up out to approaching 2 years. It's actually pretty straightforward in stenting patients that don't have a history of DVT. If it's a chronic DVT, it can be a little tricky getting through. But really, almost 70% of patients reported clinical improvement. It's about 60% of the people that had chronic lower extremity edema and 90% of the patients with pelvic pain. So I think what happens, the reason why stenting the iliac vein helps with chronic pelvic pain, and the reason I've kind of started working into ovarian vein pathology, is that when the common iliac vein is occluded, is narrowed, the blood is trying to figure out some way to get out of the left leg. And the best way to go is to go through the internal iliac vein and then either up the iliolumbar vein, which you can sometimes see enlarged on CT scan, or through the ovarian plexus and up the ovarian vein. And once it goes up the ovarian vein for extended period of time, it actually, the vein gets enlarged, the valve becomes incompetent, and all the flow goes downwards, which I also think is the same reason why 90% of varicoceles occur on the left side and not the right side. That's a hypothesis that I have yet to prove on that one. So we only had 2 complications. They were minor with access site hematomas. So we can look at the people, really the responders and non-responders, and this again just kind of talks about the lower extremity edema patients. It's about a 60% improvement, which is really doesn't feel great for the guy that's putting stents in people and have to say to, there's a 60% you're going to be better and 40% better chance that you're not. So I think there's a lot of work to be done, and this is where Stan and I are going to start collecting the bioimpedance data going forward. Female gender, which also could be, is what we found to be predictive of success, but this again could be biased based on the fact that there's a lot of the patients that got improvement were the women that had pelvic pain. So we looked at everything that we could in terms of stent data, and there was nothing that became significant in the types of stents we used, the diameters we used, the length we used, or how long of an area we stented. So again, small, to me, we have data on 34 patients. I would have hoped there would have been some signal here, which again shows to me that this is a big black box that we don't completely understand. Venography, looking at the presence of collaterals prior to putting the stent in was, slightly better than a coin toss, not much better. And similarly, whether the collaterals went away after the stent was placed was not significant. So, we really had no way of really predicting responders versus non-responders, which again is a very dissatisfying thing to have to say to my patients in clinic every week. If you look at the literature, there's some people that report a 96% success rate, which they must have magic hands or magic ways of screening patients, all the way down to 55%. So it's in line with stuff that's been reported by Reggio and Neglin, actually who's at the high end, but also Liu et al. Out of Korea. So moving forward, what I have done for actually not just venous interventions, which also include lymphatic interventions, but all of our interventions in interventional radiology, is we're actually, instead of dictating freely, into the dictaphone of, I cannulated the right common femoral artery and advanced the Benson wire, all that verbal diarrhea, which actually has no scientific merit, is that we have created discrete data field templates so that we do pick lists that then generates our reports. And those reports can be then mined by a computer robot and populate a database. So that's from our procedural reports area. In our pre-op and post-op, so this is the dictated structure reports that we have currently that we're using at Stanford across all interventions in interventional radiology. There's 12 interventional radiologists at Stanford, so it's a big program. But then we have pre-treatment data that gets inputted by our nurse practitioner, and we're working on creating a program that then will automatically generate your note. So it's a bunch of click, 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 and then boom, a note would be generated for you. That's not done yet, but is on the horizon. And then here you can see, prior contraception, prior pregnancy, DVT, and this is all actually on a web page that anyone that wants to be part of this, they can put their data in and we can archive it and store it and give it to you as you would like. You can compare it to what we're doing and our results, as well as we could put together collaborative publications. And again, the stent data that we get inputted, and post-treatment data, the SEEP score, veins clinical score, ulcer, et cetera. So, I'm going to go over a couple cases to show you kind of what we're doing. This is a 40-year-old female that had stage 2 lymphedema and by MRV, May-Thurner syndrome. She had left ankle and foot edema at age 17, treated for filariasis, and it resolved after 3 years. Then sometime later, she stepped on a nail, the leg became edematous, and it did not resolve. Her venous ultrasound showed no evidence of venous obstruction, but on MRV showed that the left common iliac vein was compressed by the right common iliac artery. So here's the MRV, and again, kind of like Stan stole a bit of my thunder, but you can see the difference in the left leg versus the right. The thickening of the skin, the black stuff here is the fat because it's a fat-suppressed image. And then you can also see the kind of the lines through here. This is the stranding. This is the edema that's in the tissue compared to the normal sides. As we go a little bit farther up, you can see the difference in the amount of adipose tissue that's in the thigh compared to the other side. You can also get an idea of what the GSV is doing if in fact you needed to do some type of ablation, and have a great view here of the popliteal vein. Actually here, this is placed. So here's shows how we scroll through all the images. You can really see how this is really a below the knee predominantly problem. It does involve the thigh. She breathed a little bit, so that's kind of this artifact. So this is an axial image, and so there's a bunch of important things to see here. This is the right common iliac vein. This coming over is the left common iliac vein, right? So all you that know May-Thurner, this is the right common iliac artery. This is the left common iliac artery. But there's two other bright dots here that should not be here. It's this thing is the right ovarian vein, and that thing is the left ovarian vein. You really should not see that typically on MR or CT. You can sometimes get fooled with the left ovarian vein. So the left ovarian vein inserts on the left renal vein. Sometimes I'm like, oh, wow, that's a huge left ovarian vein, and I scroll up, and it dumps into the splenic vein, so that's the inferior mesenteric vein, so don't get fooled by that. So here's the axial images. And here's scrolling through, and you can see the compression and how squashed that left side was. I apologize, when they put this on the PC, they actually took all the images and shrunk them. So here's the venogram, which actually shows compression of the left common iliac vein by the right common iliac artery. That's the white thing, and I forgot to point out, but she's also got an aberrant anatomy. This is her right hypogastric vein. Actually inserts on the left and then goes up. So basically, both of her hypogastric veins have impaired blood flow out of the pelvis because of the May-Thurner syndrome. So here's a picture of trying to find out exactly where I want to land the stent. This is a wall stent that's been placed. Wall stent is I used to use smart stents all the time, the Cordis smart stent, until I started doing on-the-table CT scans after they were placed. And I could see that they were actually getting a fair amount of compression, and so I've gone back to the wall stents. The reason why I didn't always use wall stents, in a training situation, it's tough to teach a fellow how to deploy a wall stent. It's like trying to teach someone how to shoot a free throw. It's like you just shoot it, and well, how hard? Like hard enough to get it there. The same thing with a wall stent. It's kind of a gentle ballet of deploying and the foreshortening and the way you angioplasty it. So it is slightly more difficult. So here is her data that you can see. Draw your attention to ankle. She's gone from 28 down to 26. Her calf 141 to 39, and her thighs. This is within error. So we had a good result in her in this case. At her year follow-up, she answered some of our questions. She felt like she was in much better general health. The throbbing had improved in her left legs, and she was able to have freer movement within her clothes. That's what I find is the best thing with patients. Like, are you wearing different shoes? Are they smaller? Are they bigger? Are your pants tighter or looser? Do you notice anything? That, to me, is a great metric. She still has edema, but it's no longer pitting. This is a very interesting case. This is one that I would hope you take home thinking about. 43-year-old woman with right leg edema, foot to groin, for 15 years. She has pelvic fullness and discomfort and painful intercourse. Minimal response to diuretics, but we'll show the imaging here. And so here you can see again, the compression from the May-Thurner and these much larger ovarian veins. We may embolize the first case if she regresses, but this is a woman that has really big, prominent ovarian veins. It's not just the size of the picture. And then the other part, this is the ascending lumbar vein here. So when I see it this big, it means, in my mind, that this stenosis is hemodynamically significant because the blood is trying to get out of the pelvis. In this woman, actually, I'll show you what we did, but we didn't end up stenting her iliac vein because a stent to me is a permanent metal device that's in you forever. And actually it does a very good job. We've been doing it at Stanford for 20 years. We've never been sued for any problems with the stent or complications from the stent. I've had many women that have gotten pregnant. There's never been an issue with baby, mom, stent, vein, clot. But if you don't have to have a stent in you, don't put a stent in someone. So what we did with her was identified, here's her right ovarian vein, IVC and aorta, and here's the left ovarian vein right here, this guy. So I consented her, this is the first person I had done this on, was embolization of her ovarian veins for lower extremity swelling. So when I hit play, this is her ovarian vein, and look right here, this faint gray area, that's flow in the right common iliac vein. It's coming out of the hypogastric into the right common iliac vein. So, and this is with her laying down. So imagine standing up. She's got this hydrostatic column of blood coming down her ovarian system and overloading her right leg. So here's her left side. So she's also got big left ovarian veins and goes down into a large venous structure inferiorly. So after I injected that left, you can see how all that blood just kind of, the contrast just kind of pulled in her pelvis. So this is, and she's laying down, right? So again, imagine how much worse it would be if she was standing up. So her ovarian system is completely incompetent and, in my opinion, overloading her lower extremity venous system. So you can actually document the continuity between the left and right internal iliac vein. So this is the left internal iliac vein being injected and filling the right internal iliac vein. And similarly, the right internal iliac vein, and when you inject it, it fills the left. So for her, I glued her right ovarian vein. We use medical grade super glue. Actually, now we use histocryl. The super glue used to be $2,000 from Cordis. Now the company makes, it's a histocryl we mix with Lipiodol, and it's $15 to take out, one ovarian vein. So I did the right ovarian vein. She was so happy with me. I said, well, let's do the left a month later, and did that. And you can see this is the left ovarian vein. I did sequentially because I wanted to see what benefit she got from the right versus the left side, because it was a right-sided problem. So these are dramatic. Her ankle went from 32 to 23. This is circumference. Like I was on the plane, I wanted to figure out how to do, the volume of a sphere, which I think is, 4/3 pi r cubed h, or no, that's, 4/3 pi, that might be a sphere. But this is it's a massive reduction in volume. A massive reduction in volume in her ankle. And we saw, slight decrease in her calf, and then similarly here. This is actually I apologize. I think my admin, it actually was on the right side. It was sorry, I think that's a typo. It was from 44 to 28, 51 to 48, 58 to 58. And she did not have any appreciable change on her left leg. So there's something happened on the left leg. The Villalta score shows an improvement in her right side from 11 to 8 to 6. So, I think what I want you guys to have as your take-home messages is that if you suspect there's some venous component to the lymphedema that you're seeing, get cross-sectional imaging from the diaphragm to the ankles, and then have it reviewed by someone that understands venous anatomy. Many of these cases that get reviewed at Stanford by the radiologist said, oh, there's no significant May-Thurner syndrome, and there is. So make sure it's someone that's dedicated within your organization that actually cares about it. If you're interested in learning more about the Vital Registry, please email me here. I spell Hofmann funny, it's 1 F and 2 N's. Otherwise, it goes to somebody at Stanford that never sends me those emails. Thank you for your time.